much, Sage. That was fascinating. And now, last but not least, we have Udbhav from McMaster to finish us off.
Right, so good afternoon, everyone. Thank you very much for joining. My name is Udbhav. I'm a second-year undergraduate student at McMaster University and a researcher in the Department of Radiation Oncology at the University of Alabama at Birmingham. So today I'm going to be walking you through my research on abdominal organ autosegmentation in order to reduce patient wait times in radiation oncology treatment students. So before we jump into exactly what the problem is, it's important to understand what a workflow looks like from a healthcare provider's point of view. So of course, in the first step, a patient is recommended for radiation therapy. This is done by a board of radiation oncologists, medical oncologists, surgical oncologists, who will get together and decide that this person would likely benefit from radiation therapy. Now, in the second step, a CT scan is done for planning. Now, the CT scan is really done to understand the internal organ structures of that specific patient. Now, you may be asking, well, don't we all have the same organs and they're roughly in the same spot, so why do we need to do a CT scan for every single patient? Well, true as that may be, every single person has unique imperfections in the way and the shape that their organs are. So this CT scan is really important for us in order to understand exactly how to deliver that radiation. Now, in the third step, the organs at risk, which is where we don't want any radiation, and the target volumes, which is where we do want the maximum amount of radiation, are identified by a radiation oncologist. Now, once those are identified, we're then able to complete a radiation planning based on these segmentations or these contours identified by the oncologist. Finally, these planning stages are complete and the patient is ready to then receive the radiation. The entire process can take anywhere from 1 to 3 weeks depending on complexity, manpower efficiency, and other factors. What we've identified and what we propose is to use a deep learning model to identify the organs at risk and target volumes, have those segmentations be submitted by a radiation oncologist for the radiation planning, and this takes our planning turnaround time from 1 to 3 weeks to 1 to 3 hours. Now, I'm sure you can see this is a fairly significant amount of time that we're able to save. Now, we've talked about a couple of steps in contouring and planning. Let's break it down. So contouring specifically, of course, in art we know, is to make a large contour around an object or highlight an object in the scene. Now, we look at a standard CT image, and again, this is a 2D image which we can take along an axis and stack together to perform a 3D analysis. And what we can see to the untrained eye is a rather obscure kind of, we don't really know what's going on here. It's just a bunch of shapes. Now, what a radiation oncologist is trained to do is to identify various organs within the scene and to highlight them or contour them in order for the planning to take place. Now, as you can see for this example scan, we've identified about 13 organs here that the oncologist identifies as being important for this very specific radiation planning. Now, what we can do, as I mentioned, is stack together these 2D representations along an axis to produce a 3D representation of organ structures within that specific patient. This allows us to target our organs at risk and to look at our target volumes. For example, we can see that the spleen is something that we're interested in here. We can see highlighted in blue on the actual 2D image, and stacked together all the way we can see it here on the 3D image. And we can do the same for any number of organs, in this case looking at the liver or even the right kidney. Now going to the second part, so how do these pictures, how do these segmentations actually help us deliver radiation? So in this case we can see that the radiation is delivered all around the patient. And what we can see is a segmented image right in the middle, where we have our patient target volume, our PTV, which is in dark red. And that's a spot where we want to deliver the most intense amount of radiation, while avoiding any of the other organs, because of course we want to avoid any unwanted side effects. So we can see that the machine will automatically tell us where it needs high levels of radiation and where it needs low levels of radiation in order to target only the spots that we want radiation to occur. And again, these segmentations now play an extremely important role in telling the algorithms exactly where and where not to administer radiation. So in order to achieve this with a deep learning model, we've used the AMOS22 dataset, which is the abdominal multi-organ segmentation dataset, which contains 500 CT and 100 MRI image label pairs. Now, in our case, we're really only concerned with the 500 CT images, and we'll discuss a multimodal approach later on. But we can see a sample image here, and this is fairly standard in our dataset, where we'll have a sample image and a sample label. Again, remembering that these are 2D images, but what we really have are 2D images along an axis, so we can bring them all together to provide a 3D representation for each one of the 500 patients. Now, in order to leverage this data, we've used two frameworks. The first of which is a UNet-R framework. A UNet is a fairly standard framework in machine learning, and specifically deep learning for medical imaging. And for those of you who are more into AI, you may understand that a transformer is something we see in large language models or natural language processing. And all the UNet R is a UNet with a transformer layer at the end, and this just helps us to linearize some of our results. The second framework that we've used is called NNUNet, and this is an AutoML pipeline that essentially leverages data analytics across our entire data set in order to produce a more accurate and cohesive model. Now this again takes the form of a 3D full resolution unit, and as I mentioned, it's very standard in machine learning. Now, how do we assess the prediction accuracy? So we give our model an image, and we ask it for an answer. We get an answer, but how do we know how good or bad that answer is? The first method is called the dissimilarity coefficient, and this is a way of quantitatively scoring our prediction results. So in this image, imagine that you have the pink circle, which is the ground truth label. In other words, what we know to be the correct answer. In blue, we have the model predictions, so what our model tells us the answer is. In this case, we can see that there's no overlap whatsoever. Not even a single pixel is correct. So in this case, we'll have a DSC of 0. Now imagine that we give our model a little bit more time to train, and now we have an image which maybe overlaps a little bit, is not completely correct, but more or less is in the right spot. And any partial overlap will have anywhere between a 0 and 1 for our DSC. Now finally, looking at a complete overlap, we'll have a DSC of 1. The other method that we use is a more qualitative method in the form of a Likert score assessment. So we provide images to a radiation oncologist and provide them with this metric. So we say you should score these images and score these organs based on 1 being completely unusable and an immediate rejection of the planning, all the way up to 5, which is that's something they would do and is clinically acceptable to move on to radiation planning. What we were able to achieve is a score of 4.7 across all of our organs, where 91% scored 4 or higher, which is only minor edits or were perfectly usable as is. We can represent this a little bit more pictorially here. What we can see is general agreement and generally tending towards a score of 5 for all these organs. Now what we haven't shown is the esophagus, the gallbladder, the adrenal glands, and the kidney, which all scored perfect 5s across the board. Well, these are pretty promising results for us, at least in a qualitative sense. Now specifically looking at the UNet model results, we're looking at the dissimilarity coefficient by organ. We're looking at all of these different targets that we've identified as being important. And what we were able to achieve is a dissimilarity coefficient of 0.849 across 7 validation images. We do know that there are some outliers due to poor annotations or other factors that we haven't yet explored within the dataset, but this is something we hope to iterate upon for the next iterations. Now looking at the NNUNet model results, again a very similar graph where we have a box plot of all of our different DSCs across all of our different targets. And we can see that we scored on 30 validation images at 0.889. This is a little better than our unit R, but we do think that there's a lot more to be had with additional training time and additional data. Now in summary, we know that manual segmentation uses valuable time and effort. We understand that CT images are crucial to be segmented in the planning process. We understand that in order to deliver optimized dose depositions, we need those segmentations to be as accurate as possible. And in order to achieve this using a deep learning model, we've used the AMOS22 dataset to develop deep learning pipelines for auto-contouring. And finally, we've been implementing these frameworks and we're currently assessing the results. So with that, I'd like to thank you all for joining and thank my collaborators, Dr. Jeffrey Peacock, Dr. Carlos Cardenas, as well as the University of Alabama at Birmingham, and JetStream2 for having provided the computational resources. Thank you very much.
Is there a reason that some of the organs would score lower quantitatively? Are they like harder to image?
Absolutely. So if we take a look, for example, at this. So you can see this yellow organ here, right? It's likely duodenum or possibly prostate. So what we can see is because it's very small, the dissimilarity coefficient doesn't really take the area into account. It only counts the amount of overlap. So even if we overlap by, let's say, 2 pixels, that's very bad for this organ, but in the grand scheme of things, it's not too bad. So these smaller organs are penalized quite a lot, and that's what we see even in the DISE-score results. The prostate uterus scored marginally lower than the others. So what we're aiming to do is then have a weighted scaling, so even smaller organs are not penalized as much, and that'll help the training going forward.
For the two different neural networks, so the networks that you used, I noticed that some of the numbers were actually quite different. So I'm just wondering how different because I don't know much about all this kind of stuff, so how different are these two processes?
So the NN unit is, so we call it an autonomial pipeline, which means we just pump in our data and then we expect a trained model to be outputted. So in terms of what NN unit does, it optimizes based on all of our different parameters. So it does something called a hyperparameter search, which essentially goes through this big network topology and says, maybe you should add more layers, maybe you should remove more layers, maybe you should make each layer bigger or smaller. It goes through all of these different iterations and finally localizes on an approach that it thinks is the best. Whereas the unit R framework is just our best guess, and it's pretty much informed by the existing literature and what we think is maybe going to work. So the fact that we got within about 0.5 of our, 0.05 of our dice scores with both networks is already promising, and we think we can get the unit R to be a pretty good result.
Could you expand a bit on the multimodal aspect of this?
Sure. So, as you know, so the AMOS22 dataset actually also comes with the 100 MRI images. So, with the MRI images, what we're able to see is, I guess, a little bit of added resolution at the expense of contrast within our images. So, what we're aiming to do is first have a CT model trained, and then we're going to try and go organ by organ and identify which ones would benefit from also having the multimodal MRI images. So, for example, images that might have more contrast, like the adrenal glands, for example, might benefit from the MRI, whereas the stomach or the liver, larger organs, would really only benefit from the CT and would likely, be penalized unduly due to the MRI.
For the different types of organs that you're trying to automatically segment,
Yep.
have you noticed any difficulties if the anatomy is like specifically abnormal? I just say this because one of the students in my lab is trying to do something similar but with heart valves, and he's specifically looking at heart valves that need to be fixed, have some sort of problem, and he noticed that if you're training with a bunch of heart valves that are typical, and then you're trying to auto-segment a heart valve that specifically has a problem that we're trying to fix, there's a lot of difficulties there. So I just was kind of wondering how that would apply here.
Absolutely. So, essentially, because we have so many images, we have 500 CT images, and these weren't selected from like especially healthy or especially unhealthy patients. These are very kind of large data set. So what we hope is that all of these images are good in the same ways and bad in the same ways, which means we can make a pretty clear distinction and have a pretty good auto-segmentation model. Now the other question is, if we, let's say we deploy this model and then we see that everyone who has a tumor in their prostate, for example, is being misrepresented here, that it's just really not working. So what this allows us to do, and the kind of beauty of deep learning, is we can take those examples and feed it back into the network, and then we have a really good cohesive model that takes in what we had originally as our training data, and now this new edge case that we've introduced, and hopefully that's in the deployment stage, that we'll kind of see, okay, is it actually performing in real world, and then incorporating those edge cases.
How hard or how long will this take to implement, or like how expensive is it? I'm guessing it's in the States, like if it's $1 or $2, but in general, like, how likely do you see this process actually being completed?
So if you're talking in terms of the actual training of the models, that does take a large amount of computational resources. So that's why we've used JetStream 2, which is a big high-performance compute cluster. Those takes weeks and weeks and weeks to train models like this. However, you're talking about actually the inference, which is the actual guesswork that the model does on the edge. We think that this can be done with very, very limited computer resources, maybe even on this. It just has to have some form of integrated graphics, and to produce an image that looks something like, let's say, something like this across all of the across an axis. This takes about a minute or a minute and a half at maximum to produce an image like this. So we're pretty confident that the cost is not going to be too much in terms of implementing it at the point of care where it's actually needed. And there are already systems like this that exist. So we're not really kind of trailblazers, and we really need a lot of GPU or compute resources at the point of care. And we think we can leverage existing